There are a couple of points. Derek, thank you very much for that introduction, because it really sets up nicely what I'm going to try to bring to you. A few little words and updates, and I don't have slides, and we can either take a few questions at the end of this perhaps, or through the questions and answer sessions. We often focus, of course, on the what we've got left to do, and you know, it's important because I'm trying to be a bit of a perfectionist. It's frustrating at times, this country at medicine, but we've in a relatively short space of time, I think our involvement, and it's not just my involvement, because Christor said another mistruth earlier on. He said he's not an expert really in NET, and that's wrong. And you become an expert in NET, and you were able to stand up at the NET Connect meeting and do us proud as an Irish surgical expert in NET. Justin Gagan, who is a surgeon, a liver transplant surgeon, technically brilliant surgeon, can come now to the NET clinic that we have every Friday morning and see patients with medical problems with NET and look after them. So this is what the whole objective was, to get physicians and people like Lisa Cullen here, who is our nurse, and I know that your nurse, I've forgotten her name, from Cork, Eric Mulvihill as well. This is the whole team, really, what we're doing every week and every day, because we got lots of emails and contacts and telephone calls, and what it's all about is this communication, and it's all about sort of reaching out to you guys here every single day, and it's happening. And it's also about you communicating between you. Tommy said maybe not enough patients know about the patient network, and you know what, I was thinking about that. That's true. So we've got to make an effort to communicate even better and increase the size of this meeting. We've had some, difficult patients over time, and I tell you, it kills us really when we can't do something valuable for our patients. You remember, and Derek was right, you're right to concentrate on the positive aspects as well, because fortunately, the people alive with the disease in the country is far more than the number of cases every year. So that's between the incidence and what we call the prevalence. Pancreatic cancer, for example, has an incidence that's far higher, but I'm talking about ordinary pancreatic cancer. And the mortality rate is almost the same, so it's a terrible disease. So, in fact, when you see that the prevalence is high like this and the incidence of the new cases are low, that's good. It's part of the disease biology, slow growing mostly, but also, and there's undoubtedly the treatments now that are available to us, treatments that we have for the most part here, and then we've got people like Barbara, who has been so generous over the last number of years. Barbara, Dick Quackerbaum, and a few other colleagues as well, that have been able to help us out with the therapies, and really that's been fantastic through people like Catherine and the group. And thankfully the government, as Derek alluded to, have been able to finance and look after us with that in mind. So it's really, really good. And I'll come back to that just in a second. So what it's all about is communicating. We've got 3 centres in this country. We've got a group of dedicated people who are more and more interested in developing their skills and their knowledge within that. And I think it's important to state also that the National Cancer Control Programme, I think probably Susan O'Reilly, and now Jerome Coffey have bought into this, and that's very, very important. I think Jerome probably now is not only the interim leader of the NCP, but he was interviewing the other day for the full job. I don't know the outcome of that, but he was the only candidate, so I presume he got the job. He sends his regards, because I met him on Tuesday morning. I was coming down and I wanted to stress a few points to him, for our Cork colleagues, for our people in Galway as well, and for patients around the country about how we're going forward. The first thing to say is that about 2 months ago, I was at a meeting for what we call rare cancer groups, and it was a European meeting hosted by Jerome Coffey in the National Cancer Control Programme in Dublin. And to my horror, the chief civil servant looking after health was in the meeting, and he's leading a new cancer strategy for Ireland. And a colleague of mine in St. James's is the person who's actually looking after it from a medical perspective. And we found out that morning that there was nothing in the programme for rare cancers. So I just stood up straight away and I said, 20% of cancers in this country are rare cancers. Now, it's not just our cancer group, but others. So they've corrected that, and it's been included now in the strategy. And there will be hullabaloo if there's nothing mentioned about NET going forward in that. And that's really, really vital, because we can't have a cancer program that doesn't include us here and other groups, right? So that's an important one. So watch out for that. And that meeting was documented. But I might be coming back to you guys for your help with this. But I think it's included now, and that's really important. It's not that we're be giving millions of dollars or euros to go forward, but if we're not in the document, we can't go forward. What other things have we been doing? It's a little update, really. Christor said about the meeting, the NetConnect meeting. That was a meeting, in fact, an educational meeting, a postgraduate educational meeting for people internationally around the world. And we were fortunate enough to host that in Trinity College. Novartis looked after that meeting. And it was a big meeting where we had a lot of experts, and that was great for educating the young doctors. And it was nice we were able to host that, Chris. I think you'll agree with that. And we hosted that as part of the National Cancer Control Net program, number 1, and Trinity College and all of the affiliated stuff. You have to do those things because bread and butter counts as well. So that went very, very well. We've had a few other meetings as well. Earlier in the year, we got together with Derek. I can't see you, Derek. Where are you gone to? Derek and the endocrinologist and the other oncologist. We had the postgraduate for the junior doctors. We got them all together. Instead of they all getting a lecture from me about medical aspects of neuroendocrine tumors or by Derek about more of the oncological aspects, we brought all of those people that come together at the meetings with the surgeons, and we gave them a full dedicated one-day program about the whole management, diagnosis, etc. So we've been trying to do that. Chris alluded to it. There have been many, many meetings, and they're going on all the time where we're actually sort of focusing and trying to bring forward that knowledge. I have a plan also personally to get involved with the Irish College of General Practitioners, that we're trying to get a program so that we can talk to the GPs about what happens in the community. We see you, for example, in Vincent's on a Friday morning, or Derek and Chris and the colleagues would see you down on another day in a clinic, and you go back out then into the community. GPs don't know what PRT is. Okay, John, you've educated your GP, and I know Terry and other people like that as well. But I think that it would be important that we would maybe reach out to them and give them an educational update on that as well. So that's part of our plan going forward. Barbara and I, and many others, were recently at a meeting in, I can't remember which meeting it was now. It was in, we went down to Nice. We thought we were going to Nice. We were in a hotel in the mountains, cooped up for 48 hours. Where we deserved to be actually, and we were trying to develop new standards of care documents. In other words, how to perform a proper scan for you guys. We call these standard operating procedures, SOPs. So we're really developing sort of standards of care guidelines. What's the best test to do in terms of biology and all the rest of it. And that went very well, I think. And we've also got new guidelines from the European Neuroendocrine Tumor Society. And I think ENETS honestly has been the stepping stone to this type of local central group getting together, us as physicians and surgeons and all the practitioners, but also you, because ENETS has really spurred on in Europe a number of developments and a number of patient groups, and it's been really vital going forward. Barbara has been one of the founder members of this group, and I was invited thereafter to join this group, and we really do work tirelessly and give up our effort and energy with no expenses, no honoraria or anything like that. It's because people are devoted to it, like Barbara has been for all of her working life, with Shellogberg, her colleague, and other people in Uppsala. But I can name now 34 European centres of excellence working like the one in Uppsala. Derek put up a few of them there. There's 6 or 7 in the UK, right? And let me just allude to something. If you're in southeast London now and you've got a neuroendocrine tumour, you have to go to a centre of excellence. You can't be looked after by some local oncologist or endocrinologist. They won't pay the money. So you have to go into a multidisciplinary group. It's absolutely vital. And if you want to go outside of that, you've got to get special permission. That's another thing. But they've actually, London now, with a huge, huge population, have got 3 centres of excellence working according to these European guidelines. People come every 3 to 5 years to audit them, experts, and they'll say, no, you're doing that wrong. You should be doing this way. So this really has been an absolute revolution in terms of improving the standards of care and management around that. And when you set up these centres, you know what happens? You get patient group who are automatically connected up to these centres of excellence, and you get access, you get funding. It's not always that easy, but it does follow on. And that's what we're about. I think that's the most exciting challenge for us, where we've applied now for European recognition in 2016. And touch wood, that'll happen. And we will be discussing with this independent group from early 2016, and we'll probably be audited then in the autumn of 2016. So that's an exciting challenge, and Cork and Galway will be part of that as well, because this will be a national Centre of Excellence group or a network. They've been, I thought Derek might talk about this, but they've been, just to bring you up really very briefly up to date, they've been at ESMO, this is the European Medical Oncology Society in the early autumn, in September. 3 new big clinical trials, really, really fantastic data coming through. One, the first what we call phase 3 clinical trial on peptide receptor radionuclide therapy. Catherine, you'd be delighted to know all of the people that you've helped go to Uppsala, Rotterdam, whatever, most of them to Uppsala, I have to say. Now all of that's been validated. We knew it worked, but now it's been validated when you compare it to a quality standard of care therapy. And it worked brilliantly. So it justifies what we felt as expert groups in using that therapy, and now we've got proper science to back that up. So that's wonderful. That is very good. We may look in the future, with the help of Barbara and our colleagues, at setting up PRT in Ireland. I think it would be logical to do that in St. Vincent's Hospital, where most of them would be sort of concentrated. But there's resource issues with that, and expert issues and all of that, and it's not that simple. And what we want to do, if we ever do it, it has to be absolutely top-notch. Otherwise we can't go about it. But we'll look into that, and we'll see. For the moment, we have the access to the really top-class centres, and that's working well. Not so many people have to go for that therapy still, but it's great to have it, as Derek said, when we need it. And thank you again for your support with that. A database. That's very interesting, because yesterday our data manager, Blonid, and myself, and Justin at the clinic, we filled out the first patients in a new database. And this is the European, again, the ENETS, or European Neuroendocrine Tumor Society based database. We have all the data in. It's a big program, and we're going to be entering patients that come to us. These are obviously anonymously entered and all the rest of it, and updated then. We try to get support to put patients into it from a retrospective manner. It's running. It needs a little bit of fine-tuning, as databases often do. It is important, because if we want to be a European Centre of Excellence network, we have to have that. That's one of the criterion. So that we have to be able, at the end of every year, we have to be able to press a button, a single button, and it uploads the numbers of new patients, the number of patients on the books, what they have, and all the rest of it. And it's really, really vital, because that's a quality control issue that we need as a proper medical group. So that's actually now working. Derek is right, and Chris will know as well, that you've had a database before. Trying to merge data from one centre to the other is always a little bit of a problem. We've had to go the way we've had to go. It's taken a bit longer than I would have certainly wanted, but we're finally there, and hopefully we can produce the same one for you here. And we work very carefully at that. Finally then, a nice bit of good news is that occasionally we've been using Octreoscan, gallium PET-CT. This is a new form of diagnostic therapy that will be available in Vincent's from next year. And I personally have worked very hard on this, but I'd like to thank somebody who's not here, called Professor Richard O'Leary, who's from Kerry, not from Cork. He, in fact, has worked tirelessly in getting a PET-CT scanner into St. Vincent's Hospital. And it's not terribly easy. It's expensive. And they've been able to do it, I think, on the strength of you, because we've absolutely beggared everybody, saying that we need PET-CT, and we can probably fund PET-CT thanks to gallium in St. Vincent's. It's not terribly, it's not an easy sort of isotope. It's not dangerous or anything like that, but it's got a very short half-life. So if you give an injection, you've all had Octreoscans, and most of you had, you've got to come back 4 hours afterwards, then 12 hours, and then you've got to come back the next day, and sometimes then day 3. You can see that that's cumbersome. It ties up a lot of resources as well. So the gallium PET-CT is an injection of this isotope called gallium. You get into the scanner and you have a normal CT scan. Basically, that's all it is. And it's a one-stop shop. It's very good. It's more sensitive and it's better. and we'll have it next year. That's the good news, okay? So that really is good. It also costs between about 70 and 90,000 a year to have a special thing called a generator that produces the actual isotope. So there's a lot of extra running costs. You could sort of say, well, we should have one in Sligo and one in Cork, but I think that having it, we're not doing away with Octreoscan. It's an important examination to have, but for a certain number of patients, having the gallium would be better. So we'll see how we get on, and then we'll discuss it about, eventually, hopefully down the road, we can maybe set up gallium. But I think, Christopher, you'd agree that having gallium on board would be really good. And you know what? It's not that difficult. I think a patient can come from Kerry, from Donegal, for a gallium PET-CT because they're only coming for a couple of hours. And I think that makes economical sense with that. And also, Jerome Coffey has been very helpful with that in mind as well. So that's, I think, very good news. And I know that we discussed this not last year even, I think it was the year before that we brought that up for the first time, and people gave some money for that. Last little thing is that in the Patient Net Foundation we had some money, and there was a request to use some of that funds to finance a program looking at genetic differences and molecular differences between patients who have got, let's say, fairly aggressive tumours and intermediate type tumours, and that's a fairly good program, and I'll talk to Mark about that at some other stage. But just to let you know that there is money there, and we plan to use it because the foundation, it's held in St. Vincent's, the foundation don't want us to be leaving money idle, so it's important that it's put into some research, and I'd like to feed that back to you as well. If anybody's got any questions on that, that's fine. And I think that there's John in the foundation as well. Chris, you mentioned this. I think raising money is an important thing, and I think we might, through the patient or through the physician group, discuss with you maybe possibilities for next year of raising some money. I think would be good. Tommy, I'd just like to say as well, before I forget, thank you very much for the organising and orchestrating the piece on not Morning Ireland, Sean O'Rourke's show. The other day. I was on it. I don't remember what I said, but somebody said that I was. My mother rang me about 10 minutes afterwards to say, I just heard you on the radio, I don't remember what I said, and I don't have the courage to podcast myself on it. So I thought Mark was absolutely outstanding to come on and chat about your own personal illness and all the rest of it. Tommy was outstanding as usual. That's really valuable, Tommy, to be able to represent all of the patients here and to help the physicians going forward, and we really appreciate that. Thanks for all you've done.